Good morning. This is Chuck Denham welcoming you to our National Research Testbed webinar. This is our 99th webinar in a row and over 99 sequential months, and we're delighted to have a terrific plan for you today. I'm on slide 3, and I just want to remind everybody to turn your volume up to the highest level so that you have good audio. And if you do not get good audio today, then you can request a separate line. And what you'll do is click on participants, then click on request phone button to receive toll dial-in, and then we can get you a better line. I'm on slide 5, and for those that do not have the slides, go to www.safetyleaders.org, and on the landing page in the right upper quadrant, you'll see what's new, and you can click on Mortality Reviews, Great Learning from Our Early Journey, and that way you can download the slides from the page I now have up, which is slide 6. And we're just delighted to have another great webinar on mortality reviews, Great Learning from Our Journey, and we really appreciate your attendance. We had over 450 registrants. We know that a proportion will watch live and a proportion will watch after they're up next week, 3 business days, and we'll have them up. We want to remind you on slide 7 of our social media links. And on slide 8, just to set the stage again, our purpose is that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. And we'll address a couple of those topics today. Our mission is to accelerate performance and solutions that save lives, save money, and create value in the communities we serve. On slide 9, you could read the disclosure statement. However, no product, service, or technology will be covered today, and for which anyone has any financial interest. And on slide 10, our speakers are Patty Atkins, who I'll introduce in a moment, Dr. Jeanne Huddleston, Dr. Mary Foley, who is a PhD RN educator from UCSF, and I'll be your host. So I'd like to turn it over to Mary to give us a 30 to 45-second set the stage for us and really get our hearts and minds connected. And I think Mary may be coming on just in a minute, while I may interrupt and have her comment, but she knew that she was on a moment earlier and she wasn't sure she'd get right on. So I'm going to jump right in so that we can move to the great presentation by Patty Atkins and the response reaction by Dr. Huddleston by addressing our news update and the results of our National Research Testbed Survey that we did and that we do each program. The one topic we've been covering, and it's an area of R&D for us, is the MedTech program that we're developing for caregivers, schools, and the public, addressing 7 leading causes of death from K through workforce. We thought it was K through 12, and we found that it's K through workforce with a special opportunity for healthcare workers in healthcare environments, addressing cardiac arrest, choking and drowning, opioid overdose, anaphylaxis, major trauma, common accidents, non-traffic related transportation accidents, including drive-over accidents, and bullying and workforce abuse in healthcare. And we just want to remind you, a terrific report, National Academy came out in December, formerly the IOM, now the National Academy of Medicine, which is terrific. It's a great update on sudden cardiac arrest, and it addresses this terrible epidemic we have of sudden cardiac arrest as differentiated from heart attacks. This is the heart stopping, especially when we have it in children and youth, in previously undiagnosed kids that and adults that have that. And on slide 15, we're addressing what this report addresses, which is critical out in the real world, and that's translating the research and the new updated knowledge into what we're doing. And after running, and we'll show a couple of studies in a little bit, but it turns out that medical caregivers and first responders have just barely borderline performance in CPR. And they're really now relooking at this issue, and especially now that so many of us have outpatient clinics where we may have support staff but not too many clinical people, we're responsible for the things that happen in those waiting rooms, and it really critical. So this article in May 10th of last year was an assessment of CPR skills using simulation. Our first responders prepared to save lives. And this is really prompting a reevaluation of the frequency of proficiency or competency currency, because we really find that the proficiency of skills was poor. Frequent basic life support training may be more indicated or more frequent at first responders to provide high-quality CPR. So this is of critical importance. As we know, heart disease is a major issue, and we have so many healthcare facilities that now have broad networks. Also, the defibrillator knowledge and know-how and being able to be introduced to the fact that these modern defibrillators really walk one through things, but the challenge that even our caregivers have is, even after they've been trained, is freezing at the time of an emergency. And that's where, as Dr. Boats has shared with us in prior webinars, immersive simulation of using deliberative practice of real-life scenarios could have enormous impact. We wanted to just let you know, because of these top 7 causes of death, that it looks like the auto-injector epinephrine access is improving. We know that there's been an enormous increase in the price of the EpiPens and the Narcan pens, but it looks like the market is starting to respond, so there's an article there for you. And then we also wanted to remind you of a terrific report and a theme that is going to be crossing the nation regarding major trauma. And the report, actually chaired by Don Berwick, that came out and was available broadly in December. It went out a little bit earlier in the year, but it addressed this issue of bystander care and the first 10 minutes after major trauma. And we know that, and this is just a snapshot. In our last webinar, we have the whole kind of a breakdown of the entire infographic. We just want to remind you it's there. We won't read this and go through it, but it's absolutely terrific, and it really drives home the critical importance of bystander care. And bystander care, as defined, means that they could be caregivers, but not the professional emergency system response professional caregivers or professional emergency caregivers. You may be a physician or a nurse or a pharmacist that has good clinical training, and yet you may be right at the site where you really need to have the skills for what's called bystander care. First 10 minutes. The average time for EMS to respond now is 10 minutes in urban communities. So we just wanted to remind you of that before we move on to Patty and our polling, our surveys. Also, the critical crisis on opioids that we addressed in prior webinars, and the issue, that issue is absolutely critical, and we've seen some of the things that are really important there. We'll talk about professional identity harm, and this is just a reminder of that. Nurse Hyatt, who committed suicide after HR records were released, and so we'll come to our poll here in a minute on professional identity harm. Coming back, though, to opioids, what we wanted to do was just let you know there's a new article that has just come out on opioids in the New England Journal of Medicine today. It addresses the delivery of opioids to nurses, opioids in the emergency department, and even one encounter can drive clinically significant long-term future opioid use. So good article, really important. I think this is one that you'll want to share with your organizations because this crisis is so enormous. We're finding in Ohio that the morgues are just filling up. It's really ground zero for illicit fentanyl use, and the number of deaths is just off the charts and still climbing, and we're seeing in pockets across the country, and this is why in our MedTac program, training people on opioid reversal is so key. Just in 2017, 150 opioid-related deaths. We're going to continue to see that pattern, and that's going to be a critical issue. So now shifting over to our topic for today, and we're so grateful and blessed that we have Dr. Jeanne Huddleston, who has led 3 terrific webinars for us. And as I said, this is our 99th webinar, and her net promoter scores for her presentation have been in the top 10 of the 100. And we'll show you the polling results here in a minute that show that we've had a tremendous response from you and our audience, and that's why we've asked Patty Atkins to speak today about their journey and Jeanne to kind of respond. So we just wanted you to know, after we had Jeanne speak, we asked the question, I am interested in a deep dive webinars on mortality reviews and safety learning systems. This is just almost unprecedented. I think the highest 10 out of 10 that we've ever had just broke 70. 98% of you agreed, attended, 68% gave it a 10, 19% a 9, and we use the net promoter score methodology, so we also look at how many disagree, and we saw that you were very, very interested in the work that Jeanne had presented. I'm not going to read each of the topics off. Please look at the slides, but I wanted to give you the complete set that Jeanne can react to. And Jeanne, we can come back to this list when, after Patty speaks, if you like. But on July 21st, when we had the survey, you can skim over the areas that the audience wanted us to address, which we will address in upcoming webinars as well. There are 2 pages. Slide 31 and slide 32 address these really, really critical issues that are issues of omission as well as commission. But the big idea there was we were really learning that there's an enormous number of issues of omission. We asked the question, would your hospital be interested in participating in a 100-case safety learning system collaborative? And you see a spread there with 17% giving it a 10, 9%, 12% 9, and on down. But not everybody, and I think this is explained by the diversity of our audiences to get a really high net promoter score for the presentation, but have a lower score for wanting to join Jeanne's collaborative, I think is explained by the broad diversity of our audience. Just reminding you of her presentation and this Pareto analysis or chart that showed that the issues of omission were enormous, and yet what we would call the errors or adverse events or issues of commission are much lower in frequency, but misdiagnosis, resuscitation, failure to rescue, procedural things, communication, triage, and infection all very high. So in September, we had her speak and said, I'm interested in a deep dive on errors of omission or issues of omission. Again, enormous response by you, and that's why we asked Dr. Huddleston to come back and talk to us about the issues and what they did about them. But this was in September of last year. And then we asked, the statement was, I'm interested in a webinar with speakers who have launched mortality review from scratch. And you can see those numbers of 57% gave it a 10. This is why we've asked folks that are on the journey to come back and talk to us. And then we asked whether you wanted more information on performance improvement. This last month, Jeanne did a spectacular job of taking what she taught us and then applying it and saying, okay, now what did we do with it, and applied their re-engineering approach to it. And I think this is the highest score that we've ever had on a net promoter score of 10s of 75%. Very strongly agreed that they wanted more information on performance improvement. The topics that we ask you to provide on free text entry, and we really hope that you'll follow up with our follow-up survey that is at the end of this presentation so we can learn more. But these topics were very right on it, absolutely critically important. So that was the polling or survey work that we did on the topic that Patty's going to cover. We just want to also address this issue in prior webinars for those that haven't seen them. The Julie Tao story that we put in a Discovery movie, the Eric Kropp story about errors and harms, systems failures that then led to the personal punishment of the caregivers, and this continuum of real harm and misbehavior versus what might be said about caregivers or organizations making someone a bad apple and then not fixing their systems issues. And we drew your attention to Dr. Hun Toon's article, Tactics and Characteristics of Sham Peer Review, and they are on slide 41. I won't read them to you. For those of you that want to learn more, go back to our earlier webinars. But then we polled the audience regarding that, and also this issue of predatory journals. And we put in the warning out to everybody. We're all getting inundated with these emails about submitted article, and so many of them are predatory journals. A great article in the Proceedings of Mayo Clinic regarding these predatory journals and fraud and misrepresentation, and this issue of what our peers could do with this, or in an organization. Slide 43 is really this issue of professional identity contamination, and we had surveyed our audience about that as well. So we're undertaking what we call red cover report case studies of issues where physicians and nurses and caregivers have had misrepresentation in their HR reports in order to validate that they were the bad apple and that it wasn't a system failure, it was the error of the caregiver. So we have two case studies here that we are sharing. One is after a patient's death of an impaired physician. A nurse spoke up in the root cause analysis, and that led to fabrication of her HR records and making her the bad apple to put take the blame off of the systems, and put it on the individual. And another is a nursing student that we've been helping and studying her case, who had great grades, went right up to the very end of her nursing training, and then when she was trying to avoid bullying by someone supervising her, they took away her opportunity to graduate, and again, a big problem. So we polled our audience in January on this topic. I am interested in a webinar on professional identity protection best practices, and you can see it's not as strong as it was for the mortality reviews, but still a very important area which we'll be following up. And we ask for free text entry regarding the topics you'd like to have covered. And I won't read the slide for you on slide 46. So we will be following that work. And so now it's such a great pleasure to really talk to you or invite Patty Atkins from Sharp Healthcare to speak. And we also have Dr. Huddleston, who recommended her as a reactor, along with Mary Foley, who I know will be back on, and we'll invite Mary to kind of speak first as a reactor. But Patty Atkins is responsible for quality, patient safety, and Lean Six Sigma for Sharp Healthcare, the largest health system in San Diego. We know them well. They won the Baldrige Award. We know their leadership team absolutely dedicated to quality. Patty led a team to launch a mortality review process in collaboration with Dr. Huddleston. She's a certified professional in patient safety by the National Patient Safety Foundation and has been a critical care nurse specialist. She served as a category lead for the Malcolm Baldrige Quality Award application, Category 4, and coordinator in 2013. And she was trained at the University of Tulsa, Master of Science from the University of Oklahoma, and she's trained in Lean Six Sigma, Black Belt, and a Master Change Agent and Master Team Trainer. So we're really privileged to have Patty address just what our audience was telling us in our surveys. We'd like to know what you learned from your early journey in the process. So Patty, please take it away.
All right. Well, thank you very much, Chuck. I'm just thrilled to be here and really appreciate Dr. Huddleston and all the work that she has brought to us. And just a little bit about Sharp, just so you understand the context of where we sit in the world. So we're in San Diego, as Chuck said, and we have 4 acute care hospitals, 3 specialty hospitals, some skilled nursing facilities, and a couple of medical groups in a health plan. We have about 18,000 employees, about 1,500 physicians, and a couple thousand licensed beds. And these are the 3 hospitals that we set up our mortality review committees. We chose these 3 because the smaller acute care hospital didn't really have the opportunity, and they have such a small group. They were already doing really good mortality review. So Dr. Huddleston we connected about a year and a half ago. We started our mortality review process last February. So we're into this about a year. And just a huge thanks to Jeanne for the inspiration, number one, that this can be done. It's a huge undertaking, but let me tell you, the return on investment is enormous, and I'll certainly elaborate on many of those things. And then just the logistics of how do you go about launching something like this in a healthcare system, and then lastly, her leadership, especially with our medical staff, and she's been extremely helpful in all of those areas. So, learner objectives today. First, I want to just take kind of that big why on the mortality review. What's our purpose? Because we can't lose sight of that as we get into the weeds sometimes. And then I want to spend just a little bit of time. It sounded like folks wanted to understand the logistics, so I'll go through our committee structure and what we have established, and how we're closing the loop on the learning. And then lastly, where I'm going to really camp out and spend most of the time is on what have we learned and what have we started to improve so far. And I'm so happy to be presenting, and there's a selfish motivation here, and that is because every time I present, I continue to learn. So I'm looking forward to the connections that I make and what I learn from your questions and from your experiences too in the discussion. So let's start with the big why. And I put these reasons in a specific order, and the first one is to create a learning culture. And I put that first because I feel like if we can do that, if we can shift away from sort of that peer review mentality across the board, we are going to gain beyond just in preventing deaths, but we're going to be able to offer the best care possible for all of our patients. And so that is really what the underlying, the foundational purpose is to create that learning culture. And that's what I feel like Dr. Huddleston is bringing in the different way that case reviews are performed. It's not looking for who did something wrong, but really how can the organization do a better job as a system, as better team members, et cetera. And part of that is creating a forum where there's multi-specialty groups coming together and breaking down those silos of the peer review over here and the nurse-led PI teams over here, and then you've got respiratory over there. And with mortality review, we've got everybody coming together, all of the different specialists from stroke and cardiac and joints, and every specialist coming together and looking at the issues that transcend every DRG. And it's been incredibly helpful from that angle. And then obviously the big why is to prevent death. I mean, that's where the gold is, right? If we can save even just a few patients' lives who should not have died in our hospital, then it's worth the investment. We are discovering many, many, many actionable insights through data, through stories and anecdotes, and ultimately we're hoping to improve our culture, our people, and our processes. So that is by shining a light at what Dr. Huddleston says, that the pan in the bottom of your refrigerator, it's kind of like all that gunk, when you start opening up the bottom of the refrigerator and you see all of these learnings. They're actionable. They're things you can take back and sometimes immediately apply. So it's been great so far, even in just 1 year. And then the other thing that I always want to make sure that we communicate is that we're not just here to prevent death, but we want to help to facilitate a good death. And sometimes that means we have to inform patients in the emergency department along the way and make sure that they have a good choice and that we honor their preferences, which, the processes around just that in and of itself I'll hit on at the end of the presentation is how do we create those processes to make sure that we have the pulse and VETS directive available when we need it. And then other times it's important to delay the inevitable death. So sometimes patients will come into our system and death is imminent, but how do we make sure that the timing is right and the experience is good in providing palliation? And so that's a big part of our guiding purpose that we can't lose sight of. And then I feel like the value-based purchasing and the CMS star rating metrics are certainly a driver, but we don't. I think if we focus on that as the overarching purpose, it is sometimes we have some conflicting values, and so it's sort of like a secondary purpose is driving home some of those important metrics that we all pay attention to. So that's the big why. Now, moving on to where we are at Sharp, and this is really exciting. And Jeanne, I haven't showed this to you, so it's I have to give a lot of credit to. Just when you look at when you start to look at it, there's some low-hanging fruit, and I'm I'm using that analogy, and we have already seen some benefit. So this is Sharp's mortality observed over expected ratio, and I've separated it by our 3 acute care hospitals, 4 actually, but Coronado we're not really focused on for this initiative, and then as a system. So we started a little bit over 1, and just in 1 year, we've been able to get under the 1.0 observed over expected. So we're not terrible, but we certainly are not great. And what we're shooting for, at least in the short term, is an OE ratio of 0.6. And I think that's been published in the literature that as one of the best one of the benchmarks for best practices. University of Pennsylvania published, and UCLA, I think, many others. And I think we can get even lower in the long term. And I know Jeanne has gone even lower than that at times. And so it just kind of gives you a little bit of a sneak peek as to where we are now. What do I credit the initial drop to? Probably a combination in our first year of continuing to focus on clinical documentation improvement, and then the low-hanging fruit with advanced illness management, which I'll elaborate on. But we also have to keep in mind that just like the NHSN benchmark, it will continue, that baseline will continue to drop as everyone gets better across the board. And so by settling with, we're under 1.0, it's not going to be good enough in the long run. So we got to keep pushing it down to that lower OE ratio. So that's where we stand. Now, this is a busy slide, and I'm not going to go into a lot of details, but I put it here intentionally so that you can see the review process in terms of the various departments and many people that are involved in mortality review. The blue boxes on the left is the review process workflow. And the purple or lavender boxes here on the right are what Jeanne calls the feedback loops for learning. And when we close that loop, we want to make sure that the learning about the review process gets to the appropriate people in the organization. And so, and you can see there's many feedback loops, and I can't even track how much improvement that we've had, because there's many times that we'll have a CNS who's doing a review and have some realization. She goes right back to her unit and we'll start teaching a class on a certain topic. And so we don't want to wait until the end and make sure that everything goes through committee and that we oversee all of these improvements. Many of them are just do-its, and they happen automatically. So that's an important realization, that it's kind of thread throughout the whole organization. Now, one of the points I wanted to make here at the top is that our goal is to screen all deaths. And I love Jeanne's motto that there's learning from every death. And we aren't there yet. I think our reviewers in year 1 got a little bit overwhelmed, and when they're on the learning curve and they got behind, and then we have our own internal database, and they were sort of taking a deep dive on cases that probably didn't need to be taken a deep dive, and until we learn how to screen really well, that time focus is is a bit of a, there's a learning curve with that. So our goal is to screen all the deaths. Now, how do we expect to do that? Because it is resource intensive. So one of the things that we do at Sharp is we use a company called Qcentrics, and there's, I think probably many companies out there that will do manual abstraction, and we have used them with core measure abstraction. We've even used for peer review abstraction, and they're excellent. They provide good reviews, and they take feedback and just bring a lot of value to the whole process. So what we're doing is having Qcentrics do that initial screen, that 10-minute screen, and then when they identify through Dr. Huddleston's 7-step process, this case is worthy of taking a deep dive on, then they shoot it back to our quality department, and then we take a deeper dive. So this whole process of outsourcing the initial review will relieve our mortality reviewers of some of the busy work and help us to simplify and focus our approach. So when it comes to the quality department, they do things like, is this a safety event? Because that's a whole other route, which I'll talk about. And they also take a look at documentation improvements. If the SOI ROM is less than 4, then we circle back and send that to our clinical documentation improvement folks. And then the quality team assigns it to a specialty reviewer, and we've got those listed, so AMI, heart failure, stroke, sepsis, et cetera. And they look specifically at those processes of care. But the unit nurse reviewer is where a lot of the gold mine is, because they understand the processes. And so by it's mostly clinical nurse specialists, but there are some frontline staff. And again, we're not quite 100% on our unit nurse reviewers, but we're moving in that direction, and teaching them how to do it in less than 30 minutes to take, one of those cases and look for what those system OFIs are. And then for select cases, they go to a physician reviewer and then to committee, and then we aggregate those findings and then send those back to the appropriate folks. So I just wanted to spend a little bit of time on some of the logistics. It's not an easy thing, but it certainly is possible, and it's been really helpful to have Dr. Huddleston's leadership and guidance, and just creating the right metrics and how to look for those OFIs. So now the meat of the talk here is, what are we learning so far? And I'm using the old Six Sigma analogy of the ground fruit, the low-hanging fruit, and then some of the more difficult improvements in the middle of the tree, the bulk fruit, and then some of the harder stuff at the top of the tree, or the sweet fruit. So just starting from the bottom up, and I'm not saying that the ground fruit is easy, because none of this is easy change to drive in an organization. But I'll tell you what, if just by focusing on the CDI, and I think everybody's probably already maxed out their abilities there, but the advanced illness management was probably our biggest aha. And when we started to do our mortality reviews and started capturing our OFIs, and one of them we called it missed opportunity for advanced illness management, it became a huge percentage of the folks that were dying in our hospitals. And it became a focus on the emergency department. And I just want to skip to this next slide, and I'm going to come back to this one while I'm talking about this, because this data was really, really powerful early on. And we found that when one hospital kind of got it immediately, and they jumped on getting their mortality review committee going, and they were looking at those early findings around missed opportunity for advanced illness management, especially in the emergency department, they hired an FTE, and she focused most of her time doing these AIM consults in the emergency department. And this is just her data of the volume of those consults in the emergency department. And I didn't do a statistical analysis, but it's pretty obvious here that it had a direct impact on the in-hospital mortality rate. And so when the other hospitals look at that, it's like, this Dilbert cartoon, there's this low-hanging fruit that hits you right in the face. And so the other hospitals are now following suit and putting those resources in the emergency department. So that is kind of like the just do it, I think, and it really is not just about preventing that inpatient admission and not taking a hit on the inpatient mortality, but it's really about providing the patients a choice and providing a good death, as opposed to sort of what we see in many reports across the country, sort of that knee-jerk intubate and then send them to the ICU, and it's for an inevitable death is always not the best thing for the patient. Now, the more that we do these advanced illness management consults, the more patients will have the advanced directives and the pulse. And so now we have an obligation to track them. And so we have this whole project going with our San Diego, the HIE, the Health Connect, the information that connects all of the hospitals in San Diego on patients, so that we can access them regardless of which hospital they come from. And believe me, that is not really ground fruit. That's a hard process to fix, but we're working on that so that we can also improve our metric, which we're calling honoring patients' preferences, because every once in a while there's a patient that we don't know has an advanced directive or a pulse for a variety of reasons, and they end up having a code blue and intubation, and so we track that as well, because that's a defect and that's harm to a patient who didn't want to be coded. And so it becomes more and more challenging the more that patients have these forms. We have to make sure that they are available and accessible to us in a timely manner. And then we also are making sure that when we have conflicts, Dr. Huddleston said we had a case where the family was in conflict over the code blue status, and she asked the question, is this the first time you've ever seen that? We all said no, and it won't be the last. And she said, well, what's your protocol? And are we using our bioethics teams to their maximum? And so that's another thing that we're now taking a look at, is what is their volume, and are they effective, and are they timely? And so, again, those are some of those things that I'm sure everybody has in place, but are we really maximizing? So that's kind of the ground fruit. I'll move up the tree here now to the low-hanging fruit. And we have, for the first time, as a result of our mortality review process, for the first time, we have brought all of our rapid response team leaders together in a forum. And now they're sharing their experiences, their model. We have one hospital who dedicates their rapid response team and these nurses. That's all they do every single day. And then two of the hospitals have a model where the ICU nurses rotate in and out, but sometimes they get pulled into staffing. And so then what we're realizing is that we needed to measure our RT uptime, or how often do we have the RRTs actually available. And we were about 85 to 90% because of those sick calls or difficulty in staffing. So we need to address those issues and say we need to put the organization where we can create the system where we have 100% RRT uptime is now our goal. The other thing that we're taking a drill down on is in doing some focus group and discussions around why don't nurses call, and we're uncovering things like they didn't know, or they didn't know their criteria, or the vital signs were put in too late, or there are some misperceptions around when you call RRT, it's sort of a sign of failure that you couldn't figure it out on your own. And so there are some cultural barriers that we now need to address, and the RRT leaders are going back and doing a lot more education around how to, when to call. And I think that the future is, and we've got a lot of discussions now, is how do we automate those calls? Instead of relying on a human to make a determination, I need to call or not, we're putting in some sort of predictive analytics, simple things like the Muse and some of the other things that within our EHR Cerner that we have reports going to the RRTs, so they're automatically triggered, so they're doing more proactive rounding. One of the things we've also talked about is how do we implement family-initiated calls, because there's been a few times where we're reviewing a case and we might find some comment like a daughter says, my dad doesn't this isn't normal for him. And so it kind of sparks that idea of, if we put a process in place where families can initiate those calls, what would that look like, and how would we benefit that? And because sometimes they are the ones who really, are worried, and they see the person, and not just, from a longitudinal perspective, and not just that sort of snapshot in time that a nurse might see in an 8-hour shift or a 12-hour shift. And that takes us to the bulk group. And this has been probably our biggest aha in our mortality review process, is that we have an opportunity, and I think this is very standard in any organization who has taken the deep dive in mortality review, that there's sometimes an inability to recognize some of these subtle signs of deterioration. And one of the very practical things that we realized is that not just our reviewers, but our nurses didn't know how to click here, and get a graphical trend of heart rate and other vital signs that you can see over a several-day period of time. And a heart rate of 100 may not seem so bad, but when you look at over the last 3 days, it started at 60 and then it went up to 70 and 80 and 90. You can now see a different picture. And so we have clinical nurse specialists, and we're doing some broad education around how do you teach people to do that within Cerner, and then to systematically critically think. And I just put a little asterisk with a reference to this article that I think is probably one of the best articles ever written about systematic critical thinking for early recognition of deterioration. And so now we're looking at these 10 indicators mentioned in this article, and it's called Nurses Worry or Concern in Early Recognition of Deteriorating Patients. And those 9 indicators, and how do you as a nurse, step by step, critically evaluate your patient for each one of those, and using your EHR to evaluate those indicators of deterioration. And then the 10th one, of course, is just your intuition, your gut check. So great article. If you haven't read it, highly, highly recommend that one. And then lastly, at the top of the tree, of course, sometimes these are the cultural things, and some things that we have realized in our mortality review is that sometimes we have teamwork and communication failures. And one of the signs that Dr. Huddleston has taught us is when a nurse writes in the progress notes, "Doctor notified, new orders received." Like, what does that mean, really? That the nurse is trying to notify the physician, but there's not an action taken. And so is that a breakdown in communication? There's maybe it doesn't mean anything, but maybe it means that there's an attempt there, and we need to provide a better system and clarity around if you don't get orders when you feel like you need orders for the patient, then what? And it's very challenging, this whole chain of command, and how to spell it out, and how do you go above a physician's head without destroying the relationship. I mean, these get into a lot of real cultural issues. So that's why I put this at the top of the tree. And we're taking a look at that, and taking a look at our policy regarding chain of command and escalation of issues. And then the EHR challenges. And this is where we get into things like everybody faces. I know I just talked with a hospital in Southern California about mortality review, and they agree they have the same challenges of things like copy paste, and do we have these two parallel universes of the nurses seeing this one picture and the physician is seeing another picture when you look at their simultaneous progress notes, and that physicians are not necessarily looking at nurses' notes, and we didn't necessarily train them in how to do that. And so we're circling back with our physicians saying, this is how you do it. You click here, you click there. And then the really sweet fruit at the top of the tree is the Mr. Delay diagnosis and treatment. And we're just putting our toe in the water. And kind of looking under some of these rocks. And, obviously sepsis, and we're seeing our sepsis mortality decline with the SEP1 bundle compliance efforts, but also stroke. We've got telemedicine for neurology, so we have, better coverage in the emergency department for those patients that come in. And so there's been some quick gains, but there's so much more. We've uncovered some things around misdiagnosis for infectious disease. We feel like we need to do a better job on some of the protocols like abdominal pain, and then some of these other things, very practical, like what is our standard for pre-op workup? And specifically, if a patient has cardiac disease and we don't have a standard, sort of a stop the line before the patient goes to the operating room in terms of their cardiac workup. And instead of leaving it up to individual physicians' judgment as an organization, we have to put these protocols in place. And we're just really tapping into all of the pre-op work around delirium assessment. And we're starting a project there, which is very exciting, which could be a whole other talk. But anyway, so that's kind of the learning and improvement so far. And then the other thing I just wanted to mention too, because it gets a little bit, I'm just going to jump past that one because I already talked about it. But this one, and this is, I looked at some of the comments in terms of what people are struggling with, and this is definitely something that we have and continue to learn in this whole process, is differentiating the reviews and mortality review versus physician peer review versus safety event review. And these lines are very blurry, and we have to be very clear and make sure that the mortality review doesn't feel like physician peer review, which is really looking for those individual opportunities for improvement for those individual physicians. And I think we all know that physician peer review and the value in terms of really driving organizational change is somewhat limited. But the mortality review, because we have those walls broken down and we have that multi-specialty look at not just individuals, but how our teams working together, what our systems and processes, it's all about learning. And there's a very different memo that comes from the Mortality Review Committee than the memo that comes from the physician peer review. And so Dr. Huddleston has helped us to, with the wording and how does the tone and the, just the whole feel of getting something from mortality review compared to a peer review. And then the other thing here, I put this 6% question mark because looking for OFIs is it's a learning process. And I was just kind of stunned, I guess, in retrospect, not so much, by this article I put down here from UCLA, and I put the link in there. But they reported that when they did their mortality review of 535 cases, that 6% they classified as potentially preventable. And so when you add up the numbers, you go, wow, that's a lot. And so how do you find those 6%? How do you classify those? And that now are we talking about if they are potentially preventable? And we are an HPI client, Healthcare Performance Improvement, on our HRO journey. And so they're helping us with the definitions of, how do you look at a complication and say, well, that, such as death or anything, and say, well, that was a deviation from a standard, and that deviation was causative to the death. So now it's going down in a whole other forum with our safety event review teams, and for those, of course, we have to do root cause analysis. So we have not identified 6%, but one of the things that I wanted to present that we're learning, and this is, I know it's kind of a busy slide, and you can sort of, take it and practice it and digest it over time, but this is something that HPI taught us, and it's called the Known Complications Test. So this is helping us to recognize an opportunity for improvement versus when you know that death is a risk and you know that someone is a very high morbidity coming into your hospital, that, death is, probably a high percentage. But how do you know? How do you tease out the question around was there a deviation? So I'm just going to walk through this. A known complication is an adverse outcome related to a procedure, treatment, or test that's not present before the patient care encounter and occurs as a result of the patient care. And so you go through these 4 questions, and the first one is, was the procedure, treatment, or test appropriate and warranted based upon nationally recognized standards of care? So there have been a few cases where in our mortality review committees, we're looking around the table saying, gosh, was that test where they had a complication and ended up dying from, was that test really warranted at that time on that patient when they were in that condition? And, was it really necessary? Could it have been delayed? Or, was there another test? And then, of course, was the patient fully informed of the risks and alternatives? And so this creates a different dialogue that I don't think that we have enough of. And it helps us to, as one physician said, gosh, it really makes you stop and think, instead of just always ordering that interventional radiology procedure or whatever, like stop and think. And so that's been a real light being shown in that area. And then the other one is, was the complication a known risk? Was it anticipated prior to the procedure? And then was the standard of care applied to mitigate the risk? And then the third question, was the complication identified in a timely manner? So this is where you get at some of the, the failure to recognize the subtle signs of deterioration. And we have to take an honest look at us, not just as an individual, but as an organization and a full team in terms of identifying those complications in a timely manner. And then lastly, was a complication which could just simply be deterioration? Was it treated according to the standard of care? And if the answer to any of these questions is no, then it is a safety event, and we do need to take a deeper dive. And I think as we apply this known complications test, we are going to probably identify more of them as safety events, and it'll be interesting to see over time what that percentage is. So one of the things I saw in that list of the audience poll was, how do you engage physicians? And I just added to that, and senior executives. And I'll tell you, probably the smartest thing that we did is we put inpatient mortality rate across the board, all payers, not just CMS, as an organizational goal. And we tie our managers and above their bonus and their incentives to it. And so it really helps to get a lot of attention here. Second bullet point here is, using Dr. Huddleston, and just the credibility of the Mayo Clinic has been an enormous helper, not just participating in it and the education that she's provided to us collectively, but her generosity of time and taking some of our CMOs under her wing and doing some mentoring on how to do a case review and saying, well, this is the standard. And at Mayo, we wouldn't do it this way. And you go, oh, wow, okay. And so just having that one-on-one mentoring has been incredibly helpful for our medical staff. Leaders, obviously using best practices from the published studies is really helpful. And I would say, and there's quite a few studies out there that I've read, to not really focus on individual physician comparisons of their O to E, unless you have a wild outlier, because there's so much debatable, debate that you can put into O to E, and so it's just, you get into a lot of circular arguments there. So instead, focusing on the system OFEs, and that's really what mortality review is all about. Stories compel, data convinces, and so we are now, because of our the database that we've created, we are now creating different dashboards. We're creating a mortality dashboard. We don't have I can't tell you today what is our OFE yield. We're thinking it's probably around 35%, but that's a guess until we review all of them and have a good denominator, and we do a good job in identifying OFEs. So that's a kind of a work in progress. But one of the things that we're also looking at is, how do you identify patients who show up and they have imminent death? And when I first started to create that metric, I thought it would be helpful to create awareness around, do we have enough resources to address the needs of these people that are showing up we identify them through comfort care only, withdrawal of life support, things that we can pull electronically. And we're still working on identifying some of those discrete fields. But what I've realized now is that when I look across our 3 organizations, that we have one organization that's lower, and you would think that would be better. But what it actually means in conjunction when you look at their RRT and Code Blue dashboard, and it has a higher Code Blue rate outside of the ICU, you say, oh, it looks like that organization isn't meeting the needs in a timely manner. And so some of these metrics you have to look at in conjunction with each other to really understand what they mean. So that's been a real help in order to drive resources around meeting the needs of AIM consults in the emergency department. And then lastly, we have our AIM dashboard. And some of the metrics there, of course, are just the referrals, and we are seeing them just shoot up as we dedicate more resources there. And it's actually helping the ED physician and not burdening them. And I think there were some misperceptions in the early days. So our referrals are going up, but we also want to see how many of those referrals are complete, and how many do we. And I think that's going to be one of our best metrics to say, if we're only at 65%, then those 35%, was it a day of the week? Was it time of day? Why were we not able to complete them? And then if they do get discharged, because not all of those patients obviously die, how are we meeting their needs post-discharge and setting up those processes? So that has been a really, helpful. So getting the data to help drive, decisions to create the systems and processes to meet the patient's needs has been a major benefit. So, in conclusion, is it worth it? Yes, absolutely. And without it, we will maintain our blind spots, and we will never be great. I mean, we'll be good, and we might get our OE down to 0.8 or 0.7, but until we really focus on learning from every death, we will continue to have our blind spots. And then just one closing thought before we open it up to the panel. I just wanted to put this in there, that we always have to remember to care for the care providers. Obviously, meeting the patient's family's needs, but our care providers, including our reviewers, because death is difficult for everyone. And I had one of the reviewers, when we were first getting launched, we had weekly calls, webinars within Sharp, and one of the reviewers said, Patty, this is really depressing. I feel like all I'm doing is just reading about death all day, and I thought, oh my gosh, I didn't even consider that. And so it is difficult, and we need to always circle back to the big why and the importance of, the work that we're doing with mortality review, so that we can provide good death and so that we can prevent death where possible. So that's all I have. And Chuck, I'll just turn it over to you and open up for questions.
Well, listen, Matt, spectacular. Really, really well done, and it's so valuable to really hear some of your learnings. I'm going to just click through real quickly so you can see Mary's face and Jeanne's face and have them react. I'll start with Mary, and I'll introduce both of them, especially since our attendees may not know them. Mary Foley is a PhD in RN. She is a clinical professor at the University of California in San Francisco School of Nursing. She's the director of the Center for Nursing Research and Innovation at UCSF. She's the assistant director for the Master's Entry Program in Nursing at UCSF and teaches in the Master's Program of Health Administration and Interprofessional Leadership. I could read on and on. She has a terrific bio, a great background. She's the APAS president of the American Nursing Association and National Student Nurses Association. She also has a personal story of her passion for patient safety and quality, and for a number of years, probably more than what she and I would like to remember, we've been working together, and she participates on a every other week call with other patient advocates. She's been a published author. She contributed to the National quality forms, safe practices, and is a terrific leader in patient safety. So, Mary, I'd like to have you kind of react to what you heard, and then we'll hear from Jeanne, and then we'll come back to you again, Mary.
Thank you, Chuck, and thank you for that wonderful introduction. You're always too generous. I am thrilled to be on this webinar. I've been following your work, Jeanne, and the work that you and Chuck have been doing over the last few months. And Patty, thrilled to see your work. I live in California, and I know SHARP well, and you guys are a shining star in our state, and you're leading our nation. And the willingness to do this gut check type of investigation is really admirable, and I hope it becomes the norm. I know it does take work, so I think today's opportunity, what you showed was how to do it. I think we're becoming easily convinced that there's a why it's necessary, preventing any unnecessary death or unnecessary suffering, because there may be peaceful deaths that we could achieve and accomplish. I thought that was a very, very important message in your work. I think we need to demonstrate best practices and help people see through the clutter of all of the initiatives and all of the reporting and all of the investigations and all of the infection measures and everything that I know our health systems are working on really diligently, because there really is a commitment to improving care. One of my current passions is the patient family engagement, whether it's patient-centeredness, engagement, activation, or co-production, whatever term you like to use. There's a rich opportunity as well to work with patient and family advisory councils in exploring some of the ideas for improvement with them as well. I'm presenting tomorrow at the post-acute conference here in California at the Hospital Association, and having active conversations about how to improve care and how to improve it with the perspective of families and patients as well. But I think this is groundbreaking work, and if I could get that slide of your tree and send it across the globe, what an amazing analysis of the opportunities for interventions, some of which are already there, getting the post-conversation and having the alternatives to excessive care and all of that explored, so important. So you're showing that, there are ways to wade through this, and it isn't just about statistics and graphs. There was a lot of conversation in that, in those opportunities for change and improvement. And all that fruit on the ground is already there and already ripening and available for improvement. So I think this is go forward with gusto. Congratulations to SHARP. And Jeanne, thank you so much for your guidance in this and giving us the insight that there's much more we need to learn. So thank you, Chuck.
Well, thank you, Mary. And I'm going to come back to you to inspire us as we close. But the great thing is that we've got some great questions. I want you to draw your attention to our national survey questions before I introduce Jeanne, because this is your chance. I'd love for you to let us know whether the statement is, I'm interested in a webinar on more detail on mortality reviews and how to safely introduce them in an organization. So any of the detail, and if you would like to know how to introduce them, we've now had webinars on the results of doing them. Jeanne's done a great job in our January webinar. I highly recommend on what they did with them. And now we have Patty, and we'll have others describe what they've learned on the journey. And now it's how do we get you to get involved? And I will promote, Jeanne, on your behalf, the collaborative. We have no financial relationship whatsoever, so I can give and all of us, I think, can give our 100% support to you and the collaboration. We're inviting you down to Texas at the end of the month to try to help recruit more people to your collaborative, because the more organizations that are involved, the more data we can draw from and the greater impact that you can have. And so thank you for leading it. So the second question is mortality review areas, topics I would like to have covered first, or like to be covered first, so that we know how to prioritize in the future webinars. What do you want to hear about first? But you can make your list, and then we'll look at the frequency of that. Then, just so we finish the survey before we go to Jeanne, the second question is, I want more information on preparing non-clinical staff for emergencies and bystander care. We have an enormous number of networks now where we're finding out that even the trained first responders who are supposedly current on CPR are just barely making it, and a number of our organizations really don't have anybody there or don't have access to AEDs and have the things that they need and are going to be responsible morally as well as legally for the care of events that may happen in those organizations and in their communities. And we'd like to hear what topics regarding bystander care we'd like to have covered. And that means that you're a doctor, a nurse, or a pharmacist. Bystander care means that you're there, and even though you know what to do, you're responding in a non-professional capacity covered by the Good Samaritan laws. And then the other two questions, again, not on the topics we discussed, but what we pulled earlier. I want more information on sham human resources reviews and employee fear of retaliation after adverse events. We know that more than 30% of caregivers on the front line, 1,000 hospitals, 1,100 hospitals pulled, 600,000 staff. They're deathly afraid of reporting anything that may be going wrong for fear of retaliation, and that was an ARC study. So we know that it's a solid study, and we know that there's a lot we can do with leadership, and we'd like to know what topics regarding human resources reviews that you would like to have covered. So those are the questions. Please respond. You guys have been so fantastic on our surveys, and they've guided us to Dr. Huddleston and to Patty. And with that, I'd like to introduce Jeanne Huddleston. For those of you that have not heard her speak, she's done 4 webinars with us, or 3 webinars with us, all spectacular, all highly ranked, great meat. It's got a lot of detail, but a lot of leadership. And Jeanne is the past president of the Society of Hospital Medicine. She's on faculty at the Mayo Clinic. She's the founder of the Hospital Medicine and program director of the Hospital Medicine Fellowship at the Mayo Clinic in Rochester. She's chairman of Mayo Clinic's Mortality Review Subcommittee, a multidisciplinary group of providers that review every death in search of where the healthcare delivery system may have failed the providers and or the patient. She received her MD in 1993, College of Human Medicine in Michigan, and completed her internal medicine and advanced general medicine fellowship at Mayo. And she is a Harvard Macy scholar, and we just consider her one of the true leaders of patient safety through this work on the globe. And we commend both Dr. Huddleston and the Mayo Clinic for being so forthright and candid and complete in helping us learn from their work. And so, Jeanne, go ahead and react and kind of build on what Patty had said. She did a great job.
Thank you very much, Chuck and Patty. Wow. Amazing to see your journey, reflecting back to when we started working together just over a year ago and seeing everything that's been accomplished. Your leadership is truly amazing. I love the apple tree. Seeing it visualized that way is a really cool way of helping people understand where the rubber meets the road. One of the things that sites who've participated in the collaborative, when they're deciding whether or not to participate, invariably someone will ask 2 questions. 1, what's the return on investment? And 2, how much will our mortality rate decrease? And I invariably over and over and over again have the conversation with them that doing reviews, reading cases about people who have already died, does not decrease your mortality rate. What decreases your mortality rate is inspiring and influencing your leadership to actually make the changes based on what the mortality review group has learned. And so seeing the things that you're already doing and how you've inspired your leadership to start putting, frankly, their money where their mouth is, and influencing the teams and inspiring the teams and supporting teams to actually make changes within your organization. Not to mention even hiring FTEs to help patients have good deaths and not even come into the hospital. It is amazing to me and very, very gets me really excited. So thank you, Patty, for everything that you're doing. One of the things that I also want to comment on is with the collaborative, the entire goal was to try to help people begin the mortality review journey and without repeating the mistakes that we made for the first 5 or 6 years that we were doing this and figuring out how to do it. We've been doing it for over 13 years now, and so we hoped that we could help leapfrog organizations forward into their journey so that they didn't have some of the bumps and bruises of ground level swell of anything new that you do. And so seeing SHARP and MedStar Georgetown and the whole MedStar group, plus all of the other organizations that are partnering in the collaborative, move forward has been really breathtaking to watch. The biggest thing, and I think SHARP has done this the best, is take the principles. So whenever I do quality improvement work, I believe in principle-driven work. These are the principles. How you implement them in your organization to make it work is up to you. Because what we did at Mayo isn't, if you just copied it letter for letter and did exactly what we did, it's not going to work everywhere. Every hospital is different, and frankly, every hospital floor in every hospital is different. And so everything has to be adapted to have the greatest level of success for implementation. And so some of the things that SHARP has done, they continue to use the database that they didn't bring on the new one that the collaborative is using, but they provided all the information to us and all the data to us so that they can continue to benchmark their work against others that are in the collaborative. And so they had to make certain modifications within their organizational structure to make it work. And the collaborative has that level of flexibility, and Patty's leadership and others within all of the other hospitals have been able to make the tweaks necessary to actually move forward. Because the ultimate goal is to learn as much as you can about care that you've already given, where something failed the providers and or the patients, so that you can make changes in those things. And how you do that organizational learning has to be multidisciplinary and multi-specialty. That's one principle. You actually have to learn together within those multiple specialties and disciplines. You have to record the information centrally so that you can learn, so you actually have data that you can use to inspire and influence your leadership or convince your leadership, as Patty said. And you have to be able to diffuse that learning across your organization. So those are the main principles. The fourth primary principle is a high reliability principle, and that's deference to expertise. Since more than 80% of what we identify are acts of omission, you need people who are in the trenches doing care to recognize what's not there. It's hard to find stuff that happened in the chart. It is really hard to find stuff that didn't happen in the chart. And so knowing what's missing, recognizing that there's a change in the pattern of how care is typically delivered, takes a clinician or somebody who's actively engaged in the practice to get the most fruit out of that. So I appreciate the way that they're doing the screening, so that the burden to those reviewers, those practicing clinicians and practicing nurses who are doing the reviews, have less burden in order to get to them. Because if you think about the Pareto principle, the 80-20 principle, so to work on the 80%, right? Our omission and commission diagram, Pareto diagram, showed that the top 80% of things that we need to work on are not hacks and HAIs. So we've been focusing on the right side of the Pareto diagram for the last 10 years in the patient safety world, when actually it's the omissions and it's the missed opportunities where we will have the greatest opportunity to improve care for patients, thousands and millions of patients to come within our organization, if we actually get to the fact where we can get at those delayed or misdiagnosis, the end-of-life opportunities, the triage opportunities, the communication and teamwork things where things fall through the cracks, the family discourse that happens around the time of death, and some of the cultural things. We just had a patient who died, and his wife was not an English speaker, and she didn't understand that his death was coming quickly, and she wasn't there when he died. And culturally, that was a huge thing, and she suffered horribly because we didn't adequately communicate with her. Ultimately, as we learn as organizations and prevent some of that unnecessary suffering, we need to learn so that we can, in the future, end the suffering caused by healthcare delivery for our patients, their families, and for our providers who suffer dearly every time they lose a patient they've cared for. Thank you, Chuck.
Thank you so much,
Jeanne.
Thank you. And just so you know, the article while you were speaking, Patty, I went and grabbed the article. It's actually available for free. We're posting it on the website where people downloaded their slides. And if you want to maybe comment on it, I put it up, and I'm sharing my screen right now, and I put the article up. But anybody, you can get it off of PubMed, and we posted it on the page where you got your slides so that you'll have it available. But Patty, do you want to take a deeper dive on this topic?
Sure, absolutely. If you scroll down to the page where it shows the 10 indicators, that's what we're really zeroing in on, and working with our clinical informaticists and saying, let's make this really practical. Can we systemize critical thinking at the bedside? So what do you click on in Cerner, and how do we teach nurses this is how you assess your patient? So many times we have patients who are agitated and they will just get some sort of benzodiazepine, or they're having pain, they get an opiate when there's an underlying reason for that. And doing a more thorough assessment and looking at the patient more holistically, not just in that moment on that shift, but what was happening 3 days ago, 4 days ago. And it was just, it's just so interesting to watch Jeanne when I've watched her do several chart reviews, and she's like a laser focus, and she will just go zing right to the issue, and she looks back 3 and 4 days prior to a code blue, and she'll be able to pinpoint exactly when things started to decline. And it's usually very subtle, but identifying these in a systematic way and then teaching nurses it's not a concept, but this is what you click on in your EHR in order to see those. That's what we are. That's what we're doing now. But in addition, we have to not rely on humans in order to pick these things up. So we're looking at what can we do in terms of the computer working for us and using some sort of predictive analytics tools, and I know there's many out there, and a lot of folks are kind of leading the way in that. We're looking at what Intermountain has done with their early predictive deterioration score, and how do you put that in so that you can look at it at any given point in time and say this patient is at a risk for deterioration, and can then trigger the RRT to automatically come and not wait for a nurse to detect it. So I think that is where I'm hoping to be in a year from now, having those systems in place.
Fantastic. Jeanne, do you want to comment on this list? And then, Mary, do you have other comments that you'd like? And those of you that would like to ask questions, please enter them in the lower right quadrant of the screen. And so what I'll do is ask both of you. One of the questions that was asked is, how many people do you have, Patty, on your staff to do this work? And Jeanne, what recommendations do you have those that are considering this in terms of staffing up, staff time, and resources?
Patty, go ahead.
Sure. We have about a total of, in the quality departments, we have a total of probably 12 or 13 reviewers. They're not doing it full time, but they're the ones that are responsible for going to the chart and then recording in our database what the OFIs are that they find. Beyond that, we have what we call specialty reviewers, and so we have cardiac specialists and neuro specialists, and so they review it for a specific focus on their their disease process, and did we identify the right patient, patient selection issues, and then also did we, provide the right diagnosis and treatment. So in all, I think we have about 20 reviewers, but they have different responsibilities within the whole program.
Great. Any comments, Jeanne? And then we'll ask you about pharmacy and medication reviews. Jennifer Bone has asked that question, but Jeanne, thoughts about how many people one should anticipate as you get started?
What I recommend to people is basically to do 100 cases first. Get some champions, some passionate people, or support somebody's FTE if necessary, and just do 100 cases to figure out internally what your own resource needs are going to be. Everybody's issues are a little bit different. Politics are a little bit different. Organizational structure is a little bit different. We did our first 100 cases with 2 docs and 1 nurse. And out of that, we learned about what kind of process we might want to do. And that's the sort of hopefully leapfrog people and help people move past all of that learning that we did. We currently have representation from every clinical division and department within our institution, and all of our nurse managers and CNSs participate in the review process. We work hard not to give anyone more than 2 reviews a week. The reason for that is Mayo Clinic calls work that takes less than 5% of the time citizenship. So we try to not burden anybody with more than 2 hours of work a week. And if a tough review might take an hour, an easy review might take 15 minutes. But we try to not give anybody more than 2 reviews a week. And so those are basically the resources. But in terms of starting up, I recommend just starting with 100 cases, figure out if it's beneficial for your institution, figure out if you're going to learn anything, and then if you've decided it is beneficial to move forward, then you'll have a much easier way to justify the FTE, what you're learning, and what it's going to take to get it done.
Great. Mary, any reactions or questions? And then I'm going to ask the question or ask you all to respond to where are medication errors in pharmacy review? But Mary, comments, thoughts, questions?
Yeah, I think I'm processing this on many levels. I really appreciate that article. I think we've been playing around the term failure to rescue for a while, and it's been relatively either limited or unspecified. And I thought the list of 10 was really telling, and I think the example that Jeanne gave of, you medicate just because you see the symptom but you don't know the cause it's part of our health system. That's how we've done our work. It's what the doctors do. It's what the nurses do. And so that was very really a helpful article to give some meat to that. So what should we be looking for? The other question I guess I have, thank you for using the direct care nurses because, of course, they have the insight and also family. But I wonder what kind of support and critical incident work you're doing with the staff. I would imagine there's some demoralization of, oh, my God, I missed this, and could I have done more? And no one goes to work wishing that they or goes home wishing they could have done more. They go to work to do the best they can. So what kind of support is there for the insight gained that, yeah, we missed the clues, we failed this family, this death didn't have to happen at all, or at least not in the way it took place?
We do a couple different things. One, we have conversations with the actual care providers in order to gauge where they are. Sometimes those conversations turn into support conversations. We have the nurse managers who are participating in the reviews who know the frequency with which those things are happening on their units. And what we encourage everybody to do is turn them into educational opportunities because, frankly, anybody who misses a diagnosis, they're one of at least 40,000 people in our institution who have missed that diagnosis too. And so we talk about the system that has failed the providers and therefore the patients, and that if we had better point of care resources, more support for our overworked, cognitively overloaded providers, then these things may not be happening. And so what's been interesting is that when our Bedside Patient Rescue Initiative came through to deal with the Deteriorating Patient Initiative, every nursing floor was on board. And when the docs tried to shut it down because it was going to interfere with their culture and people were going to be automatically paged without them knowing about it, the nurses stood up and said, we need this. We have cultural issues. We have team issues. We need support. And it went forward because our nurses wanted it.
Yippee.
And that was amazing.
Yeah, that's great. That's a great example of making it part of the culture.
Yep.
Yep. And preventive efforts, not,
Yep.
not repairing it after, it's preventing it in advance. Wonderful.
Right, because
Thank
we've
you.
all experienced it.
We all have.
We've all had a patient slip through our fingers.
Yep.
Fantastic. And I, after you, we'll ask the question about medications and pharmacy. One of our attendees wanted to ask, where do they fit in there? And then I'd like to come back to this, Jeanne, how you deftly named the issues and Patty, the opportunities for improvement, and we get out of the name, blame, shame cycle. And how you kind of, if you're in an environment where that happens. But let's ask the question about medication management, adverse drug events. Patty, where does that kind of fit in the structure?
Sure, and not just related to patients who have died from, for example, opioid oversedation, but for those who have even received Narcan unplanned. And so one of the things that we're moving towards is putting in a report within our EHR that identifies patients who are at risk for oversedation, and our pharmacists, our safe medication practice pharmacists, are reviewing that list as a potential, and then taking a look at, what is prescribed and intervening prior to the oversedation event. So that's sort of a newer initiative in the realm of preventing adverse events. But some of the other places where pharmacists have been involved is in med reconciliation errors. And so looking at what are those processes and who's responsible, and how do we put, pharmacist consults on discharge or pharm tech consults in the right place, through the hospital stay. So it's been truly multidisciplinary, and you can't ever leave out the pharmacist for sure. So part of it is workflow and roles responsibility, and part of it is using that technology in innovative ways.
I'm going to slip another question. One of our participants asked as we go to maybe have you finish up on this, and then Jeanne cover the meds and hospice. Do you include all deaths and hospice patients? Was one of the questions, and then we'll go to Jeanne and just couple up hospice and medications. So Patty, do you include hospice patients?
We include all inpatients. So if they are hospice but in OBS status, we don't include them. So, but any inpatient that might be on hospice is included.
Gotcha. Jeanne, hospice and medication management.
From a medication perspective, we have a pharmacist who attends all of our monthly multidisciplinary, multi-specialty case discussions. And when our medication issues that have come up, they are so adapted actually getting into the system and figuring out when it was ordered and what time it was given, so that we can have a meaningful conversation around a medication event. Those events are then all forwarded to our medication event team, because they may or may not have been surfaced, typically not surfaced in the sorts of things we find in mortality review. So that's how we include them. We don't have them spend time going through the charts because the yield is just not high enough. The HACs and the HAIs and the medication events are still so rare that going through every chart looking for a medication event would not be a good use of someone's time. We look at all deaths in the hospital, whether they happen in the emergency room, hospital, outpatient, inpatient, whatever. And we do look at those that are comfort care only and or hospice. Now, those are typically really fast reviews, especially if they came in for respite and they, died 2 days later or something while they were in the hospital. Those don't take very long, but we look for safe medication practices. We did have a death where someone died after receiving a 50 milligram bolus of morphine instead of a 5 milligram bolus. So we know that those things happen. We look for adequate pain control, because suffering at the time of death is something we have noted, whether it be agitation, pain, or respiratory rate, or secretion control, but those are the areas we continually fall down on in terms of the suffering related at the time of death, and trying to get to a point where all patients in our system have good deaths. So yes, we include hospice for those reasons, and yes, we do have a pharmacist involved, but just at the monthly meeting. Your question,
Yeah, go ahead.
Your question about OFIs, opportunities for improvement.
Yes.
13 years ago, when we first sat down and we were debating the preventability of a case, it became very, very clear that we didn't want to talk about preventability, because we very quickly stopped talking about the fact that the patient died with a pain score of 9 for the last 2 days of their life. So we left the world of preventability and we left the world of adverse events. When I'm sitting in a room and we talk about adverse events, docs' eyes and most of the nurses, they all of a sudden have sunglasses on, some sort of shade where they're not, and if you watch their body language, they lean back. So we call everything issues. Everybody's got issues. Every parent of a teenager has issues. Everybody's parents have issues. Our kids at work, we have issues. Issues is a very culturally acceptable way to talk about stuff. So we talk about issues, and it's fascinating when you're sitting in a room and you start talking about, oh, we had this issue with this patient. People lean forward. So all we're doing is leveraging our cultural way of speaking to actually get further into the case and remove the shroud of, or that veil that people put over adverse events. We don't use the words adverse event, preventable, or anything in any of our group conversations. We've translated that those issues are actually opportunities for improvement. And so in the collaborative, we call them OFIs. What we want to hunt for are opportunities for improvement, and we identify issues. And that language has helped facilitate and move us away from some of the shame, blame, so you can have nurses and doctors from across your institution sitting in the same room and having hard discussions just by changing the language. It's been fascinating to watch.
Fantastic. I'm going to ask Patty if there are any conclusionary sort of statements, but I just want to thank Jeanne and you, Patty, for a terrific job. We're going to bring others. I just talked with another wonderful communicated with another wonderful source from you, Jeanne, to bring back for our webinars, and we're just going to continue to focus on this really, really important area. Patty, fabulous job. Any conclusionary thoughts? And then we'll go to Mary to wrap us up. And if the speakers could just stay on so we can do our own process improvement loop and know how to serve you all better, that would be great. But Patty?
Sure, just real quick, regarding supporting the nurses on the floor and physicians as well, we actively provide employee assistance program support and make sure that they have that available. But beyond that, we're moving into some peer support programs. So that's been something new. Partly that's originated from the adverse event circle, but also when it comes to death in general, especially when they're young people that die or babies that die, we really need to have not just EAP, but also peer support groups. So there's great stuff in the literature that we're taking a look at and look forward to implementing those programs.
Fantastic, and thank you for the reference to the article, and for the live attendees, we've already posted it up on the website so that you can have access to it, and for the on-demand folks, it'll remain there for you. Mary, would you close us, and we'll wrap up, and God bless you all, and I hope you just have a wonderful rest of the week.
Well, thank you, Chuck, for continuing to support the webinars and the learnings. I saw almost 300 participants almost for the entire session. It's just remarkable how committed people are to improving care. And I think it's because we know it's us or our family members or our loved ones who could be sitting there in that bed hoping that we're doing the very best every time we show up and give them the options that are available. So it's a privilege to be part of this group and to have worked with you. And this topic is remarkable, and there is progress being made and much more to come. So thank you again, and good wishes to everyone.
Thank you, Mary, and thank all of you for attending and participating. Our next webinar is our 100th webinar, and I think we're going to bring some of our greatest speakers, and I'm going to ask Jeanne again, and we'll be recording Jeanne in Texas, and so I think we'll have a fantastic webinar for our 100th webinar in March. So many thanks to you all for your support and for putting this stuff to work, and Mary, thanks for those wonderful comments. Have a great week.